Okay, welcome everyone. Thank you for attending this education session tonight. It's about the new NIP schedule changes starting from the 1st of July. A special welcome to our participants who are video conferencing online. Before we begin, I'd like to give acknowledgement to the First Nation people of Australia, the Aboriginal people. For today's purpose, I would like to give particular acknowledgement to the Bindal and Walgarukuba people, past, present and future, who are traditional owners of the land on which we are meeting today and on which we walk, work and live. A little bit of housekeeping to begin with. Emergency exits, either side, the doors, and out the front doors and across onto the grassed area over the other side. Toilets out through the foyer and across the corridors. Could you please turn your mobile phones off? And people who are on video conference, can you please mute your video conference? Thanks.
Yes.
The one who just said yes, our microphone is muted is not right.
And there'll be evaluations. Everybody who's registered tonight, there'll be evaluations online to your email address in the next few days. If you could please fill them out, that would be great. And now I'd like to hand over to Dr. Stephen Donoghue, our Director of the Public Health Unit here in Townsville and Public Health Physician for North Queensland. Thank you.
Hello everybody, can you hear me? Can you hear me online? Oh, you don't have to answer that because you're on mute. Right. Now, it's very easy to tell people about a change in the schedule. It's hard to explain why. And I'm going to try and do some of the whys here, as well as a few updates on some related topics. So just some things that we've had some difficulties with flu vaccine and supply this year, as well as some rumour mongering that I want to work with. What's been happening with meningococcal disease that has terrified the government into finally bringing in the quadrivalent vaccine. All of the stuff around, or some of the stuff around Prevnar and why there was an interest in shifting that, and of course what's happening to the Hib dose as well. The maternal doses that are now on the national schedule, and also some very interesting stuff about what's been happening with mumps, if we've got time. Michelle will follow me with some more information about AIR and usage of AIR, as well as adverse event reporting, which is incredibly important. Okay, so just stop me. There's not a great number of people here, and even the other sites, if you want to stop me for a question, just turn on your microphone and give it a yell. All right. So I guess the first thing about this year is that there have been all of these stories about shortages of flu vaccine, and I know we had a problem, Mandy, here in the hospital. We were running out of stock and we couldn't even finish our staff vaccination program, and then completely unexpectedly we got more doses, and we're more or less right now, but that interruption did put us a bit behind, and we're still playing catch-up weeks down the track. Now, the information from the government has not been very helpful. Nothing to see here, no shortage, don't worry about it. But that's not what I'm hearing from the world out there. So in terms of the National Immunisation Program stock, that is for the risk groups, hands up the people who have experienced a shortage. Right. And how many people have experienced questioning about their ordering? Do you really need so much vaccine? Yeah. And how many people have experienced a shortage of the private stock? Right. Now I know more than I did before, because, I mean, the interesting thing is that some of these media releases were clearly inaccurate. You know, the government spokesperson says, oh, don't worry, we're making more flu vaccine, it's going to happen in Melbourne and the stock will be here in 2 months. Well, no, flu vaccines are grown in eggs. They take at least 6 months to produce. And if it was made in Melbourne, how come some of the vials of vaccine are turning up with foreign languages written on them? So it sounds like by hook or by crook they've been buying from overseas or diverting stock that was actually in production for the Northern Hemisphere winter. and just reusing that here, because most likely Northern Hemisphere will be the same strains that we've been using in our winter. So come Christmas, we don't expect any big changes to that. All right, so there definitely have been problems, and also there's been a bit of rumour mongering going around. So I guess the key problem is that we just didn't order enough as a country, both for the government and the private stock. Predictions were wrong. We had a really bad year last year, particularly the H3N2. That's a variety of flu that tends to affect elderly people more. And also because we were introducing so many new products. So for the first time, the national program was offering vaccine to children 6 months up to 5 years. Always have been a high-risk group, always have had the odd quite severe disease, even deaths in children. And the other main thing about young children is that they are the ones who spread it. I mean, young children, let's face it, are disgusting. If you've had young children, you'll know what I mean. And they are the ones who spread it around. So it's actually quite an important risk groups. And I think partly that's why there were so many problems around it. We've also been putting a lot of effort here into nursing homes. We know that both staff and residents are important. Residents will get sick, but they're actually quite hard to vaccinate. They don't respond as well, elderly people, to standard vaccines, and that's why they brought in the higher dose vaccines or the adjuvanted, stronger vaccines for the elderly over 65. We had some advice that went out about, don't use your flu shots until closer to the flu season. I didn't want that advice to go out in North Queensland because in the tropics you can get flu outbreaks at any time of year. In the southeast of Queensland or southeast Australia, it's more reliable. You get your August, September outbreak. But up here, it's a risk, and I didn't want to do that. But still, that was the advice that went out, and so it led to some delays. And so, as I said, there was all this spin in the media about there's going to be more stock. Things have improved, but there still are focal shortages, particularly the specific products that you have to use under 3 or under or over 65. Yeah. So it sounds like the private stocks have caught up a little bit as well, which is good. And it's still not too late to vaccinate, of course, because we fortunately haven't seen the big uptake or the big uptick in flu numbers so far. We had a little bit earlier in the year. Right now there's very little around, but it will come back. And so that's just the table that we've been using to talk about some of the products out there and what to do with the different age groups. I tried to come up with a way of memorising this and I completely failed. So I just tell people, look at the table and, don't think too hard about it. So the media go berserk about flu every year. And they'll say, we've had record numbers of flu so far this year in Mackay. Meanwhile, Townsville has had fewer numbers of flu so far this year in Townsville or something or other. Whatever will make a story. But of course, all of the dribs and drabs of flu that you have prior to the big winter flu season have absolutely no bearing on how big the outbreak is going to be in winter. They really tell us nothing. And so it's almost impossible to predict how bad the flu season will be before the flu season starts. Right? Unless it was a pandemic strain that none of us had immunity to, and then we would know that we were in trouble. The other beat up in the media was that somehow the elderly were being shortchanged because it was still a trivalent vaccine with only 3 strains. And they claimed that the missing strain, the one that's in the 4-valent but not the 3-valent, is the terrible Brisbane strain, which is the big killer. There's hardly any of it around this year. It was only 4th priority anyway. And I think it's only 10% of the flu B isolates so far have been what is sometimes called a Victoria lineage or a Brisbane lineage. So again, complete beat up, no substance to it. Elderly people do not need both vaccines. The best vaccine for the over 65s are the enhanced ones, which again I'm going to have to go back and remember the names. Fluad and Fluzone. That's right. All right. So some GPs ask the question, shouldn't I be giving it to both? Giving both to the elderly? And the answer is no, that's a complete waste of time. And there's no data that says that it's any better. Your question?
Yes, we were also vaccinating children with the private, no, with the public schools. The ones over 5 were having it. They're the private ones that we had to buy in. And they would have had 2.
All right, so this is, yeah.
Then the pharmacies ran out of that, and we couldn't buy it from the private. And then a comment was made, well, at least they've had one, that should be okay. So I don't...
All right, the question is, in children, what happens with the recommendation that in the first year you give 2 doses a month apart during a shortage? Now, if you really only had 3 vaccines, probably even in under 5s, you'd be better off giving 1 to 3 different kids than giving 2 to one child and 1 to another. Some children will respond well to even a single dose, and if you miss giving them a second dose in the first year, you wouldn't do that in the second year. You would just give them 1 dose. But yeah, we did run into problems there, and then people had these dilemmas about how to use their remaining stock that were really difficult to answer because often we don't have data to answer the questions. But I think the choices we made in the hospital was to really try and maximise the people who'd at least had 1 dose of any vaccine. And for that reason, over 65s who'd had the normal flu vaccine, if we're short of over 65 vaccine, maybe they don't need a second dose. But in circumstances where you have enough stock, you would have actually repeated it. So thank you. That was an important problem that came up. So the whole thing about giving an adult and an elderly, don't do it. It's a waste of time. It's not funded. And we don't even know whether it would be any better. But certainly that particular problem was very small and did not cause the shortages. So any other comments or questions about shortage? Yes? Efficacy, yes. I want the flu zone versus the fluad. Yeah, so the problem that we have now, right now, is that we don't have any clean data that compares flu zone and fluad head to head. All that we know is that they're roughly equivalent, and there is a lot of work, research in medicine is like that. I talk about, equivalence studies rather than head-to-head studies. So what we were seeing were typically 30, 40%, 20%, changing year to year in the over 65s responses to standard vaccines. But with either of these, either the adjuvant or the high-dose product, we were getting an additional 30%, roughly, in any year. And so there's really, at the moment, nothing to compare them. The reason why governments often buy multiple brands is as an insurance policy in case there is a shortage or a manufacturing problem. So there really is nothing to choose between the two, and anyone who claims otherwise is making it up. Thank you, that's a good question. All right, so that's the flu epidemic curve that we see in most years. This is Queensland-wide. In North Queensland, you'll often see a little bump there in February, March, April. We certainly had one last year, and there was a little one this year as well. But you can see that running along across the bottom there in April, May, June tells you nothing about how big the curve is going to be during the southern winter flu season. So last year was a real shocker, very large numbers. Mind you, the numbers were bumped up by increased number of testing. You've got to remember that the statistics is the tip of the iceberg, the people who actually were sick enough to go to the doctor and the doctor was interested enough to do a test and that test was reported and went into the statistics. Most cases of flu don't present and are not tested. So that's another reason why these figures are not necessarily accurate and why last year may not have been all that much bigger than previous years. So the luck of the draw. Your immunity to flu depends on the H and N proteins on the outside of the circulating viruses. the luck of the draw this year and last was that there's a lot of H3N2 out there, but H1N1 is still circulating, which is very similar to the pandemic strain that went around the world in 2009. So H3N2 are slowly changing as the H1N1 is slowly changing. But again, if somebody had H3N2 last year, they're likely to still have protection. But that would be not a reason not to vaccinate them, because we usually don't know what strains individuals have had in the past. Because so many people had H3N2 last year, you could guess that maybe this year will be less severe flu season than last, because it was pretty widespread last year, and often they have an off year, just like the Germans won the World Cup last year and now they're out. Yeah, it's a bit like that. Now, vaccinations in pregnancy are now official nationally. Anyone who tells you that this is not a good idea and we don't vaccinate pregnant women is dead wrong, okay? So flu is really dangerous in pregnancy. The natural immune suppression of pregnancy means that flu can kill pregnant women, and it can kill newborns if they haven't had antibodies from their mothers. Yes? Good question. The question was about afluria quad, which is for 18 years and above as an adult vaccine. Does that mean that you shouldn't use that in pregnant women under 18? In general. Oh, right. Now, you've got to remember that a lot of these age restrictions are simply around what data the manufacturer presented to the authorities. So if they did a research in 18 years and above, they can't claim efficacy and safety for 17-year-olds, even though it's pretty clear that it's exactly the same kind of vaccine that they have in the other adults, and there's no reason at all to suppose that a 17 would have a problem. So, unfortunately, we do have to obey the recommendations where we can, but am I going to lose any sleep over a 17-year-old or a pregnant woman getting that vaccine? No. It's almost certainly going to work, and we know that all of these flu vaccines are safe in pregnancy. Yeah, the data is in. They might get a sore arm, they could get a TEM like the rest of us, but it's not going to hurt the baby or cause premature labour or any of that stuff. It's been looked into, that's why it's now on the national schedule. Thank you for asking about that. All right, so you can give flu, I'll start again. You must give flu vaccine during every pregnancy. I don't care what time in the pregnancy, as soon as that woman is in your clutches, ask about flu vaccine, yeah? You can use flu vaccine up until it expires. And these days, most of our products will actually remain in date for a full year. So you will have stock up until you get the following year's stock, and then you can discard. All right, so you should keep in reserve flu vaccine for pregnant women at any time of year. It's that important. In fact, there are circumstances, as they describe in these brochures, where you might even want to give two different annual vaccines during a pregnancy. One at the beginning and one at the end if they're different years. That's perfectly legitimate and protects the newborn as well as the mother. Now, giving a pertussis booster during pregnancy, again, is safe. It's now an official part of the national program. The small d just means that the diphtheria toxoid dose is smaller than that we give to children, because these are now boosters. Right, and so it's just a dose difference. Ideally, you give the Boostrix or Adacel in the third trimester, and they talk about 28 to 32 weeks. And what you're trying to balance here is, we do know that the peak of the woman's antibodies is about a couple of weeks after giving the vaccine, and so you want the vaccine antibody response to peak at around the time that the baby is born, so that they come off with a good load of antibody from their mother. But if you leave it too late, she might deliver before you got the jab into her. So that's for, any time in the third trimester, or if you don't think you're going to see her again, I don't care what trimester. So we had a woman the other day who'd had a tetanus-prone wound. I said, well, give it to her now. You don't have to give Tip-Tox and then later on. Just give her Adacel right now, even if it's in the first or second trimester. Every pregnancy is the rule, and there's a huge reduction in those horrible cases of neonatal pertussis. They're the ones that kill children. So 90% reduction, that's good, isn't it? Yeah, it's still a common cause of neonatal deaths or infant deaths. So minor reactions. Now, the last thing I've got on the slide there is administrative controls. What the hell is that about? Can anyone tell me? What does it mean, administrative controls? I gave a lecture on management issues today, so I'm right into this. Anyone? You do not get all of your pregnant women vaccinated by talking, or by reminding, or by begging. It just doesn't work. I want you all to go home, go back to your practice, and introduce something in the standard paperwork or on the computer that it's an essential step and you can't just forget it. Yeah? It's a standard part of the process, just like doing your antenatal bloods. It's got to be in your list, it's got to be on your protocol, it's got to be in the record. Right? It's called an administrative control. It means that it's foolproof. No idiot can ignore it or forget it. Yeah? So we're no longer in the stage where pregnant woman flu or Adacel is optional. Yeah? I'm telling you. So if you get sued, don't come crying to me. All right. It's there and it's basically obligatory. You can tell your doctors I said that. Yeah. Absolutely. That's what I mean by an administrative control. If they haven't done it, you should buy some better software or remind them to update it. Right, Michelle?
Yeah, it's often a matter of just getting the updates.
Yeah. Administrative controls so that we're not relying on idiots. And look, just the other thing to say about flu is just because we've been emphasising vaccine, it doesn't mean that there are other things that are not equally important. All of the research, all of the modelling suggests that during the flu season, ordinary hand washing, covering your coughs and colds, staying a metre or two back from somebody who's coughing and sneezing is really important. And even if it doesn't stop everybody from getting the flu, it flattens out the outbreak so that it's more gradual and slower and doesn't put huge pressure on the beds or intensive care for the severe cases. All right, so all of that stuff about ordinary hygiene is still there. We haven't abolished that just because we've got newer and better vaccines or more people getting it for free. All right, so I think that's all I wanted to say about flu. I wanted to talk some more about some of this meningococcal stuff. Apologies to some of you who might have seen some of these slides before, but it's really important to understand why we're moving from this meningococcal C vaccine to the quadrivalent at this time, etc., etc. So we'll talk about the epidemiology, how it's transmitted, what we do with contact tracing as public health, and why we give antibiotics very quickly, and then some more about the immune system and what these new vaccines are capable of, and what's happening to the incidence of different strains of meningococcal in Australia. So the problem with meningococcal, of course, is that it's a rare disease. And you could go your whole career without seeing one. If you miss it, or if it's bungled or mismanaged, somebody could die or lose their limbs or have some horrible outcome. That's why it's really important to talk about it. And including the characteristic hemorrhagic or petechial rash. Anyone who's really sick, getting worse, and that comes out, antibiotics, off to hospital. Don't muck around. Yeah. So it's a human germ. It's worldwide. The invasive disease might be rare, but quite deadly, even today. The incidence is probably only about 1 in 100,000 a year. And most cases are one-off, but occasionally you'll get little clusters or even outbreaks, for example, in prisons or army camps or colleges, etc., among young people. And of course you get the big outbreaks that happen in Africa and at the Hajj in mecca from time to time. So we know about the risks of meningococcal disease. Certain age groups. Can somebody tell me the age groups? Who's at most at risk of meningococcal? Young babies, and who else? Teenagers. Why teenagers? They snog. They socialise. And why young babies? Their immunity isn't so good, that's right. And so, in this case, it's the teenagers who are spreading it. Remember I said with the flu it was the toddlers who are spreading it? With meningococcal, it's actually the teenagers who spread it in the community. And those most at risk are actually the young children. And then the rest of us, there are not so many cases. So we know about age, we know about overcrowding, we know about people who've got new partners or newly gone to a college or something where there might be a different meningococcal around. Travel is a risk, and it's a travel medicine. Indigenous communities have got a higher incidence. Anyone with an immune deficiency, particularly problems with the spleen or the complement system, which is in our blood to kill certain types of bacteria. People who smoke because it affects their respiratory tract. And obviously we think that one of the reasons why we have a winter peak in meningococcal is because these germs can hitchhike on other viruses, and that gains entry from the nose into the bloodstream. So it's likely that it's kind of hitchhiking. And the problem with these serogroups is that there are about a dozen, only about 5 main serogroups, and if you're immune to one, doesn't make you immune to the others. That's what a serogroup means. There are different serums against the different groups, meaning, unfortunately, we're not immune to all of them. And the problem in the community is that if you come out with a really great vaccine against meningococcal C, because it's the common one that is out there, then you can knock that on the head. Meningococcal C is now rare, isn't it? But to some extent, certain other serogroups or other types of the organism can come up and increase in number. Usually not as much as the original knockdown, but still a problem. And that's what we're seeing now with meningococcal, as you'll see. So, not so much vaccine escape, but replacement strains. Oh, what's that nurse doing there? Anyone? Not the fontanelle? Oh, yeah, maybe you're right. I thought she was checking if the neck was stiff, but now I can see that she actually is looking at the fontanelle. Maybe she's doing both at once, which would be really clever. All right. Now, meningococcal is not a flesh-eating bacteria. They love putting flesh-eating in the media. It's complete nonsense. It's not Ebola. It's actually not particularly infectious. It is notifiable on clinical suspicion. And the reason is that occasionally we get secondary cases. A few years ago there was a case in a town not far from here where the doctor correctly diagnosed meningococcal, sent the case to the hospital, did not notify. 3 days later, a relative died. Whose fault was that? The doctor who did not notify. Because no contact tracing was done, no warning was done, and somebody up and died very quickly. It happens. All right, so you've got this balancing priority between the privacy of the case and the rights of the contacts who need to be told. And this is a common problem in public health and contact tracing, isn't it? And certainly there are all sorts of fears. People all try and take antibiotics if they've been within 10 yards of somebody with meningococcal, but that's actually not necessary at all. So I'll talk about that. Meningococcal germs, they spread just through sputum, droplets, actually through snot, not saliva, comes from your nose. Usually it's people who live closely together. It's quite uncommon to get it from a casual contact. All right? This is a big bacteria, not a small airborne virus. Usually households or dormitories or girlfriends and boyfriends. Pure saliva does not contain meningococcal germs, so if you share a glass or a fork, it's probably nothing. We've spoken about A, C, W, Y and B, which are the main serogroups. The problem with the B is that all the meningococcal are difficult for the immune system because they're covered with a slimy sugar coating called polysaccharide. And it's actually really hard for the immune system to latch onto sugars. Proteins, that's easy, but sugars is difficult. And so the serogroups are about the polysaccharide coating on these bacteria, and the 5 main types are quite different. But the B type, the reason why we haven't been able to vaccinate for a long time until recently, is that those antigens look like something very similar to human central nervous system. So most people would tolerate it, but if you did make people immune to that particular capsule, you could end up with an autoimmune disease, right? Because it's so similar to something in our own bodies. So it's been really, really hard to get a vaccine against the B, which I'm going to talk about, and just a little bit about contacts. So I'm going to tell you the story that I go through this with every contact of every meningococcal case. Contacts are those who lived under the same roofs as the case in the 7 days before onset. Right? So you really have to share a house or more than 8 hours in a plane next to the person. Casually dealing with them as a health worker doesn't count. You would only be a health worker contact before they were properly treated, you intubated them without a mask. And you are heavily exposed to respiratory secretions. And even then, your chances are minimal, probably 1 in 1,000 of getting the disease. Anyway, this is what I tell a contact. This is a feared disease because it can kill people within 24 hours. A lot of people have heard of meningococcal. The disease is rare, but the germ is common. This is very odd, isn't it? 10% of the people in this room will be walking around with meningococcal in their nose today. And minding its own business, not doing any harm. The person is basically immune to it and it's just sitting there. It's a commensal. So we don't really know why it invades the body now and then, particularly in the very young or the immune suppressed or people who've acquired it recently. It may be that it's piggybacking on a virus. It might be something funny about that person's immune system, or it might be something funny about that particular strain of meningococcus. Everybody's immune system is different, and sometimes there's just a chink in our armour or something odd about that particular person that doesn't respond very well to meningococcal. So what lots of other people have tolerated is about to kill you. And unfortunately, we don't know enough about how that works. But the other funny thing about meningococcal is it's usually not the patient who's spreading the disease. After all, the patient is really sick. They're mounting a massive immune response. They're fighting it. Whereas maybe in their household or among their close family-like contacts, there's somebody who's quietly sniffing away and spreading this particular organism. So the reason why we follow all of these contacts is not the reason you might expect. It's not necessarily to protect them so much as the fact that they might be the one who's the spreader and could give it to a third person. So as a contact, your chances of getting the disease are very low, about 1 in 1,000. The main reason for contacting them is to give them a warning, not an antibiotic. And that warning is very simple. If you or anyone close to you in the next few days or few weeks was to get really sick, progressively sick, getting worse, with all of those typical signs of sepsis or meningitis, so fever, headache, nausea, vomiting, confusion, neck stiffness, photophobia, severe headaches, collapse, unconsciousness, coma, kids who are just irritable and can't eat, people who are getting aches and pains, particularly for some reason in the legs, in a person who's really sick. They're the signs that people who are contacts must not muck around, right? Day or night, if you're a contact and you get those symptoms, go to a doctor or hospital, tell them that you're a contact, and then it's all over. The doctor knows what to do. They give you an antibiotic. It's very easy to kill this germ with antibiotics, and then it's finished. But if you wait, if you muck around, then you could get a severe disease. This thing is frighteningly fast. All right, so that's the spiel. The close household contacts, we give them what's called a clearance antibiotic, which means that if they are the carrier, this will remove it from their nose and they won't give it to Auntie Jean or to their boyfriend. That's the main reason for the antibiotic. If they're actually incubating the disease, one dose of antibiotic is not going to stop it. Right? So you happy about that with meningococcal? Who's seen a case? Yeah, a good few of you. Yeah, it's nasty. All right, and that's just a symptom chart that we give out to contacts, what to look for in the babies on the right and adults on the left. Babies can't do very many things. They just generally don't look well, and the mothers can tell that they're not well. And of course, if they get the rash. All right, so these are the things that we could use for clearance antibiotics. Really depends on the age, whether they're pregnant, whether you can trust them to take tablets. Sometimes with kids it's just easier to give them an injection of ceftriaxone, or if she's pregnant, that's a safe drug. But there are really good reasons not to overuse antibiotics. As you know, you could end up with drug-resistant bacteria, gastrointestinal problems, waste of money, lots of panic among the staff. But something that people don't realise is that if you kill the good germs in the nose, you could make it easier for the bad ones to get in. And that seems to be a real factor with meningococcal. So don't overdo it, and as a staff member, you hardly ever need an antibiotic for dealing with one of these. All right, this is just a general talk about trying to make vaccines for difficult bacteria. Remember I said that these encapsulated bacteria have got this slimy coat around them called polysaccharide. Meningococcal, pneumococcal, and Hib. Those germs have always been really big killers of toddlers and babies. Why? Because the young person's immune system is not very good at dealing with sugar antigens. Yeah? Slimy, sugar-coated bacteria are really hard. And it's really hard for them to mount an immune response based on the sugar coating. So the easiest way to make a vaccine is to get the germs, grow them, grind them up into little pieces and inject that. Did it work for meningococcal? No. In fact, you got pretty nasty reactions because it's got all of the constituents of a very nasty bacterium in it. So whole cell vaccines failed. And if you just got the polysaccharide skin, you could get a response to ACWY, but only in older people. So over 2 years old. Yeah. You might respond. And in the younger kids, who are the key target group, we didn't get any response at all. So it was an adult vaccine, essentially. Those polysaccharide vaccines are now obsolete because they don't work particularly well. All right, so what else could you do to get at the Cookie Monster? Well, with difficult antigens, there's another thing you can do, and that is to link the polysaccharide from the coat of the bacteria to a protein. So some protein that we're really good at using, for example, diphtheria toxoid, tetanus toxoid, very well understood. If you can chemically link the polysaccharide to a protein, then the immune system will respond magnificently. So this was a huge triumph in vaccine manufacture. It's only been around for 20 years or so. Before that, they just died in large numbers from these diseases. And now suddenly, whether it's pneumococcal, Hib, or now meningococcal, we can immunise children to protect them from some of these top killer diseases. They're expensive, but they work beautifully. Other things that we do with vaccines, of course, is we use things called adjuvants. An adjuvant is an added ingredient that more or less says to whatever you've injected, hey, immune system, come and have a look at this. It keeps it in place, it flags it to the immune system, and sometimes you'll get a better response. Just didn't work with meningococcal. So probably the last resort, and the most costly, and the most high-tech, is recombinant ingredients. In other words, we actually get the DNA or the RNA of the germ or the virus, and we grow it in something else so that it's completely dead, harmless, and we find the particular components. So sticking through that sugar coating are tiny bits of proteins of various types. 4 different proteins were used for the meningococcal B strains, and even then we haven't got all of them covered by the vaccine. All right, but this is really super high-tech. In other words, something that looks to the immune system like those dangerous proteins, but is in fact harmless. And that's now why we've got meningococcal B vaccines, but they're still not on the schedule. They don't work the same as the conjugate vaccines. In fact, they're not as good as the conjugate vaccine. So any questions about that? Okay. So this is what we've been saying. These encapsulated bacteria are hard for the immune system of infants. Now we can conjugate them. We can get long-lasting and high-level immunity. So much so that the polysaccharide vaccines are basically obsolete. Yeah? Although we still use a pneumococcal polysaccharide vaccine called Pneumovax for older people, don't we? But for kids, we've got Prevnar and Synflorix, which are the conjugated vaccines for babies. So we've done really well with the meningococcal C vaccine, but now we've been forced to change over to the quadrivalent meningococcal conjugate vaccine, whereas the meningococcal B vaccines that we have are other proteins, and they work very differently, and yeah, that's still a problem. Yep.
Still, a lot of our doctors still promote Bactero.
Bexaroid, yep.
So, even though they haven't, is it still one to promote?
Yeah, so the question is, should we be promoting the meningococcal B, for example, Bexaroid? Yes, I'm coming to it. If I had a baby today, I'd definitely use the vaccine. Yeah. I thought it was 2 and then 3.
Sorry, 2 and 3, sorry, 3 to 12 months.
Yeah, yeah.
So some people are opting for 12 months of doing 2 doses.
Right, so this question is about the doses. Can I come back to that question when we get to the slide about when you would do it and how many doses? All right, so I've moved the old polysaccharide meningococcal vaccines to the right because I don't think they even make them anymore, but people might still have it in their history that they've been vaccinated in the past. First of all, we conjugated the C, and then we conjugated it with Hib, which was Meninterix. That's the vaccine that you will still have in stock. You can use it as a Hib vaccine at 18 months until you run out. It's a perfectly good vaccine. All right, so there's no problem giving that instead of Hibirex. Yeah, so don't throw it away. This stuff is great. And it's been hugely successful in almost getting rid of meningococcal C in Australia. But then the 4-in-1s, Nimenrix, Menactra and Menveo, are all really good conjugates against A, C, W and Y, and there are some differences in the ages. And again, that mainly depends on what data is available rather than is it likely to work. So for the 1-year-olds, the program will be using Nimenrix. And then with the recombinant meningococcal B vaccines, which are actual proteins, there's 2 brands on the market now, Trumenba and Bexaroid, and I'll talk about that. So Bexaroid, this is what we were saying. If you give it to infants, you can give it with the normal schedule, 2, 4 and 6 months, but it's 3 doses. It's pretty expensive. Now, initially there were some concerns about Bexaroid. 1, it didn't cover all of the meningococcal Bs, and it still doesn't. 2, there hadn't been very much experience with it, so we weren't quite sure how good it was. 3, we didn't know how long it lasted because it was a new vaccine. And 4, the research hadn't been about reduction in meningococcal B so much as secondary endpoints, namely that you had antibodies that should kill those. And the reason for that is that it was really hard to do prevention trials for a rare disease. You would have had to recruit hundreds of thousands of children. So they had secondary endpoints in the trials. But having said all of that, it's now been around for at least 10 years and it's working beautifully. And as I say, if I had a baby, I would fork out and get this vaccine. Would I fork out before 12 months or after 12 months? Depends on how much money I've got in my pocket. If I can afford 3 doses in a younger child, I would use it because we don't want the child to get meningococcal B before I get around to vaccinating them. So you have the advantage of earlier protection. The other thing about it is that there was fever when you gave it with the standard vaccines. This is the only vaccine where we actually recommend giving paracetamol prophylactically if you're giving it with the other vaccines. These kids do have more fever, and of course that increases the risk of febrile convulsions slightly. All right, yes? That's right. So it's part of the national program in England. Yes? Anything else? No, any other questions about so far? I thought I saw another hand.
Is it for under 2s or can over 2s as well?
Look, I think the main thing is the under 2s. That's when you've got the hazard of febrile convulsions. Much over that age, and it's much less of a risk. They probably will get a fever, but it may not be important. I mean, we've moved on from the days when we think that all fevers must be treated. We're specifically worried about febrile convulsions in the under 2-year-olds. Thank you. All right. And the other thing about Bexsero is that we don't give it to meningococcal contacts of meningococcal B because it works too slowly. You'd need 2 or 3 doses over several months. Whereas the conjugate vaccines, if we've had a case of meningococcal W, for example, then we will give the contacts as soon as we know because they will get a rapid response to that vaccine and that would further reduce their chances of getting a secondary case. All right, so you all happy about that? I hope it comes onto the national schedule. It's really about cost and priorities and deals with the drug companies. This other brand, Trumemba, so far the research has only shown that it's working over age 10, so from 10 to 25. It's only 2 of the 4 components that they used in Bexsero, but they seem to be getting good results, and it's probably cheaper. So if you've got somebody in that age group, it's probably a more cost-effective option, but I haven't checked the prices. But yeah, so it's a Me Too kind of vaccine. But no reason to think it's not going to work. All right, now this is the history. This is an important slide because the different colours represent the different types of meningococcal over the years since the year 2000. And those bright blue bars on the left, they were getting out of control. We were having really high rates and lots of deaths from meningococcal. And very soon after introducing the meningococcal C conjugate vaccine, it just disappeared. It would work like magic, all right? So don't let people tell you that vaccines don't work. This was unbelievable. Unfortunately, the B kept marching on, right, because we didn't have a B vaccine. But even now, over the last few years, you can see that B has begun to drop off, partly, I think, because more people are using the meningococcal B vaccine. But I can't guarantee that, but it's probably the reason. The other thing to notice is just in more recent years, suddenly the W, which is the red, and the Y, which is the green. I'm colourblind, so I ask for assistance with it. The pink is the W. Teal and pink. Okay, whatever. I'm going to give you a close-up of the more recent years. Now I can see it. This was very worrying, and the same thing happened in other countries like the UK. They suddenly started seeing many more meningococcal W and Y, and not only were there more of them, but they were behaving differently to meningococcal B and C. We were seeing disease in older people, elderly people, and very odd presentations. So we were seeing cases of septic arthritis, pneumonia, abdominal pain, epiglottitis, ear infections, all sorts, and eye infections, all sorts of funny things, and also a high mortality rate because it just looked different from meningococcal and they were further down the track before they were treated. So it was very worrying. But since we've introduced the quadrivalent, first in the school program and then in a GP catch-up, and then here in North Queensland because we had some outbreaks in the Territory and the Northwest, we started giving it to Indigenous kids who were in contact with the Northern Territory. And now, of course, introducing it into the 1-year-olds, we're hoping that that's going to go right down and stay down. I think the Movi one is just the ones that haven't been serogrouped yet. Yeah, just untyped. Most of them these days you do get a type, and now and then you get some that are non-typable or X or one of the others. But the big ticket items these days is the Y and the W, and of course we're still seeing the Bs. But much better than it used to be. Right? So they're really forced to make a move because of this whole business of replacement strains that weren't covered by the vaccine. It hasn't got to the level that it did in the early 2000s, but it's still a worrying increase. So they're trying to head that off. All right. So as I say, virulent strange presentations, younger and older, more severe disease. And then we had an outbreak with that strain in the territory in Indigenous communities. Why Indigenous communities? Poverty, malnutrition, overcrowding, all of the reasons that you could expect, far from health services. We were terrified it was coming into Queensland because we had an import case from the territory, we had a conjunctivitis with the same strain, and more recently we've had an actual case in Doomadgee, I think. But because we've done a lot of vaccinating now in 1 to 19-year-old children, as well as the 15 to 19 catch-up for the school program, we seem to have headed it off. And now I'm really pleased to say that we're introducing it for all children from 1 year of age. Yes, we did. Yes, we had a death. So there's still quite large numbers of meningococcal happening this year, and that's going to come out in the stats. So we haven't really headed it off yet, but we're hoping in the next year or so to bring it right down again. People who've had quadrivalent meningococcal conjugate vaccine in the past, like all of my kids, I was terrified as well, they can have it again. So having a second dose later on is not going to cause any harm to your immunity and might in fact boost it. So if you have the opportunity through the school program, meanwhile you've already done your kids, that's fine. But at the 1 year program is just a single dose. At a population level, that's going to work, even though it may not be perfect on an individual level. So nowadays, the kids will get a dose at 1 year of age and in year 10. Yeah, year 10 at school. And that should cover them for infancy and then for the high-risk group for spreading among the youth. Right, anything more about meningococcal? All right. Oh, this is just talking about the school program and the catch-ups that we can do at the GPs, all right? So that's really important. Okay, that's a really good question. So women or parents who haven't had the benefit up until now, they're seeing that it's now available on the schedule. Should I go and buy it? Again, my answer is, my kid, I would do it. But some people can't afford it. And of course, once you're 10, then you're not in that infant risk group, but you've still got the teenage risk group. Yeah. My daughter's 20 and she's working in a medical lab. So did I give it to her? Absolutely. Yeah? So, yeah, if you can manage to get that, hopefully the prices will fall further as well. All right, just another reminder about pneumococcal. Three nasties, Hib, pneumococcal, meningococcal, are all those encapsulated bacteria with the slimy sugar coating. Pneumococcal causes invasive disease, that is septicemia. It also pneumonia, of course, meningitis, sinusitis, otitis media, etc. Remember, the reason why Pneumovax 23 can't be used in young babies is because it's a polysaccharide vaccine. Yeah. The key problem we've got with pneumococcal is there are dozens of different types with all those complicated numbers in the table. And then people look at that and they say, well, isn't Pneumovax, the 23-valent, a better vaccine because it's got more coverage? Well, and the answer is no, it's a different technology. If I could choose a pneumococcal vaccine for a high-risk adult, I'll tell you which one I would give. It would be Prevnar 13, because it's a conjugate vaccine, high immune response, long-lasting, and some cross-protection between strains. Pneumovax 23 is a horrible old vaccine. Can anyone tell me why it's horrible? Well, it's not a very good immune response. I'm not saying it's not worth using, it's better than nothing. It doesn't last particularly long. Then you have to give further doses, starting when they're 50 or 65, depending on whether they're Indigenous or non-Indigenous. And every time you give a further dose, you could get worse and worse local reactions, yeah? So people start reacting against it, and then you're sort of balancing the risks and benefits of the vaccine versus the reactions. We try not to give people more than 2 or 3 doses in their life for pneumovax. Yep. Money, my dear. Money is why we are not giving more adults pneumovax Prevnar 13. But those at high medical risk, when they ring me up, or Michelle up, we quietly sometimes bend the rules and ask them to use a government baby vaccine in that person. And hospitals will do the same, isn't it, Mandy? Yeah. So just remember that Prevnar is a damn good vaccine because it's a conjugate. It's much better than pneumovax. Michelle?
So, Stephen agreed a month ago that we would actually give an extra funding to the selective patients. So, but please make sure that you get the selective patients onto the selective register. If you can get Victoria to actually put down funds money into that Victorian selective register as this So please make sure that the patient gets onto that register because we actually need enough evidence that some of these patients there are
Yes. Thanks for reminding me because remember I said that these encapsulated bacteria, it's people with complement immune deficiencies or an inactive or absent spleen who are at very high risk. Yeah, so absolutely those people need the conjugate vaccine. Yep. Yeah, so the question is, if you're over 65 and you can afford it, should you have a Prevnar 13? Yeah, in addition to a pneumovax. But there are issues around the gaps between them. It would be better to give the Prevnar first and the pneumovax second because otherwise you have to wait a long time. Yeah, so my mother, I'd give her both. Yeah. There was another question about the pneumococcal vaccines. Are you guys online okay about all of this? Good, we'll continue ignoring you. All right, now the other thing that's popped up and what has been in our back pocket for a while is there have been doubts about whether or not giving Prevnar at 2, 4 and 6 months was the best schedule because we were seeing breakthrough cases even among the strains that were covered by Prevnar 13 in older children. And so the theory now is if you delay the 3rd dose of Prevnar till 12 months, you're probably going to get more bang for your buck. In other words, a better immune response, longer lasting in a slightly older child without losing too much in the first year of life. So there's always been that theoretical argument that if we have the chance from some other change to the schedule, it would be nice to move the last dose of Prevnar to 12 months. So let's see how all of this works out. It's called 2 + 1 rather than 3. The +1 being the 12-month dose. All right. So currently we're giving meningococcal C and Hib in 1 dose at 12 months. You could give Hib with meningococcal ACWY, but it's probably better to also delay the last dose of Hib. We're going to change to Nimenrix, which is a quadrivalent meningococcal, at 12 months, and that means that we move the Hib dose onto 18 months. So at this stage, they will be supplying you with Hiberix, which is a monovalent Hib vaccine for 18 months. But if you've still got Meninterix in the fridge, right, which is Hib conjugate and meningococcal C conjugate, by all means, brilliant vaccine, use that. It's probably better than the monovalent Hib in my book. All right, so don't chuck it out. It's good stuff. All right, and we were talking about a single dose, although it's not always recommended, is probably enough at the moment to protect the population generally in terms of transmission. And therefore you may see some differences in what's written in the product information inserted in the box and what are the recommendations of the program. And of course remember that there are older people with risks for meningococcal, including travel, people who work in labs, recruits for colleges and military and young Indigenous people, etc. Question? To have?
To have their interest, that's what we were currently doing, so they can give you the decision.
Yep.
Are we now just going to giving them in 1 month or telling them, sorry, don't worry about it, I'll give it to you later?
Right, now for those online, this is the type of question that I refer to Michelle. So the question is, some of these Indigenous kids, we've already given them Nimenrex at 12 months and we've asked them to come back for their Menitorex, meningococcal C plus Hib, in a month. Do we still do that or would you wait for 18? Michelle, that's your question.
Short answer is it's okay to do it a month because you're actually not going to have active, which is the branded DTP for 18 months. They're going to give to those kids that are having Nimenrex at 12 months, will get an active at 18 months. So you're not going to be told to throw out your Menitorex. So the short answer is yes, you should give it.
I knew that. So Michelle said yes, you probably should give it at 1 month and then still give the next dose of Hib at 18.
No, you don't have to give at 18 months. The Prevnar actually, those that are going on to the 12-month schedule of Prevnar will probably get the 2, 4, 6 and then 12 months.
Yeah, I'll talk about that, Michelle. Now she's going on to Prevnar. All right. So when you're coming up with vaccine schedules, it's a bit of a trade-off. You're trying to work out what are the points where these kids are coming in, hopefully, and when you're going to get the best bang for your buck with the vaccines. This isn't the actual situation, so you don't need to photocopy that. But it's this whole idea about, well, can we move this? How do we juggle things? How many doses do we have to give at different times? And so this is basically a reminder of the changes, given that we're only giving you a short, small page version because the official posters haven't arrived yet. They will be sending them out this week, the new vaccination schedule posters. The one that we're giving you is probably too detailed and I need my glasses to even read it, but there should be something better. But this is just what's changing. Clearly I haven't got the birth written at the top there. The birth doses are really important. Hep B, every baby, regardless, and BCG for those who need it. And then they're probably going to say 2 months now instead of 6 weeks, just to simplify things. So it'll just say 2, 4, and 6 months. The Hexa, the rotavirus vaccine, and the first dose of Prevnar 13, the same for the medically at risk and the Indigenous. Same again at 4 months. Yeah, so 2 injections and the drops. What happens now at 6 months is just 1 injection for most kids, but 2 injections if you're medically at risk or Indigenous. In other words, their extra dose is actually not their last dose. It's going to be the 6-month dose continuing. So the high risk and Indigenous getting 2 injections, everybody else gets only 1 injection at 6 months, which is great. Of course, it's a 6-in-1, and we know that works. Parents who worry about giving lots of vaccines at once, don't worry. This is an amazing immune system, and they've proven that it works. But at 12 months, now we've got a bit of a package there, haven't we? MMR, meningococcal, and Prevnar, and of course, if you're Indigenous, a 4th vaccine, your Hep A. Yeah, and then at 18 months, 3 injections, MMRV, monovalent Hib, because that's been moved, and the DTPA booster. And Indigenous kids, again, 4 injections. So 3 or 4 injections at 12 and 18 months. Now, the disadvantage of giving more vaccines in older children is that older children can fight back. Right, so you're going to have to pay more attention to how mother is holding the baby and how you calm her down so that the baby feels secure, even though she shouldn't feel secure. Yep. So that's the disadvantage. But the advantage is from the 2+1 schedule, or the 3+1 for medical at risk and Indigenous, is that we're getting stronger and longer lasting immunity for pneumococcal. Right? And we're also getting those kids with the 4-in-1 meningococcal, which is brilliant. So are there any questions? They're not huge changes, but it's just something that we now have to get used to. Yep. Yeah, if you've got meningitis, absolutely. There's no problem in giving an extra boost to their meningococcal C immunity. No problem whatever. In fact, it's a bonus. Yep. Yeah, 2 months instead of 6 weeks. What was the reasoning for that, Michelle? Do you remember? So look, we will forgive you if it's at 6 weeks, but I think advertising it at 6 weeks wasn't particularly helpful. I think that was the answer, Michelle.
I think the reason is that they're actually now advertising it at 2 months, but they do have a dot point in there for the national information to say that you can give it from 6 weeks. The reason that they're actually putting it like that now is because they're actually anticipating that because they're going to release the national ADACEL program for pregnant women.
Oh, that's right.
Anticipating that pregnant women are now getting that vaccine. So therefore the baby doesn't need the earlier vaccination, but you're not going to be in trouble if you give it at 6 weeks.
But no earlier than 6 weeks. Yeah, so I knew that too. Michelle's quite right. If the woman gets it in pregnancy, then the baby has a much less chance of getting pertussis as an infant, and therefore the 6-week recommendation is not so important. There was another question? Yep. Yeah, so the question is there a catch-up schedule for ACWY? The answer, unfortunately, is no. Those parents would have to buy it. At the moment, rates of W and Y in infants are still low. If you could afford it, it would be a reasonable thing to do. Yep. Yeah, remember you've got time for the hip. You're not going to need it for 6 months. And so they will be sending out the Nimenrix first, but there will be plenty of time. And, of course, you can use up your Meningerix. But the Hibarix, yeah, it will come. There's no problem. Anything else? Yep. No, not at all. No. You can do it from 6 weeks, as before. Yep.
Remember, it's just starting as a national program. We've been doing it as a Queensland program for a lot of years now, but it's only just gone to the national program now, so I suspect it'll be national program in the future.
But Michelle's quite right. If she's actually had her pregnancy vaccines, she'd be better off at 2 months. Yeah, but if she hasn't, I'd be going for 6 weeks. But yeah, it's about the messaging to make it less complicated. Yep.
What we educate our mothers is that at 6 weeks they need to have they will need to disclose themselves, so they're actively teaching.
Yeah, that's right. Yeah, so if there's a 6-week check, you don't want them to come back. You just give it on the spot. Absolutely. Thank you for that. All right, let's move on. I wanted to talk to you a little bit while we've got a bit of time. How much time have we got? Okay. A little bit about what's happening with mumps. Now, I'm always banging on about measles and how terrible it is and how MMR is the most important vaccine. I'll repeat that. MMR is the most important vaccine. But something funny has been happening with mumps. I'm going to go through this really quickly, and it is complicated, but if you'll bear with me, we're starting to see a lot more mumps, and people are wondering what the hell is going on. All right, so mumps is actually related to measles. They're both RNA paramyxoviruses, and they're both spread in much the same way, respiratory droplets. They're pretty infectious. Measles is extremely infectious, but mumps is also quite infectious. Mumps has got a longer incubation period. The virus hangs around for possibly a little bit longer. Most cases will get parotitis. It's usually on both sides, but sometimes it's only on one side. Sometimes it's on neither side. Sometimes, occasionally, mumps can complicate by going to other glands. So other salivary glands, your pancreas, your testes, even your ovaries. Yeah, some people can get encephalitis. You can get permanent hearing loss. Fortunately, severe neurological complications and deaths are rare, and most mumps cases don't turn up at hospital because they're mild. In fact, about 20% of them are completely or asymptomatic or so mild that somebody wouldn't even go to the doctor. So parotid gland is up there behind the angle of the jaw and the ear. It's quite different to your submandibular salivary glands. And as I said, some of the complications like encephalitis, they used to be classically more common in older people. So one of the problems with vaccinations of, for example, rubella or measles or mumps, is that if you're going to introduce a vaccine for a disease that most people get in infancy, you've got to be damn sure you're doing the right thing, because you don't want to simply increase the average age of people who get the disease. For example, young women who are getting rubella while pregnant. That would be doing more harm than good, isn't it? So all three of these are examples of diseases. Also chickenpox, by the way, that if you're going to vaccinate nationally, make sure you do it properly, because you don't want people getting these diseases when they're older rather than when they're very young and it's very mild. Same for hepatitis A, by the way. It's probably one reason why we haven't introduced Hep A vaccine for everybody. So you would exclude people mainly, from the onset of parotitis, it's just 5 days of exclusion. It's pretty easy. It doesn't cause teratogenesis in pregnancy, but occasionally it might be involved, as with any infection, in a miscarriage. Right, so it's just simply exclusion. We don't have a treatment. All right, so we've been using mumps in MMR vaccines since about 1983. Initially, they were getting further cases in older children, exactly what you don't want, so they introduced second dose MMR. And we use the thing called Gerald-Lynn strain because there are fewer vaccine strain side effects. And most people, at least initially, were getting long-term, if not lifelong, immunity from 2 doses. Remember, the second dose of MMR is not so much a booster as an insurance policy. Some people, maybe 10%, don't respond to the first dose of MMR, and then you mop them up by giving a second dose, and therefore nearly everybody is immune who's had 2 doses. Similarly with mumps. You can't give it in pregnancy, it's a live vaccine, or people with immune deficiency. In countries where everybody's vaccinated, you get extremely low rates of mumps. And the other thing that is different to measles is after exposure to measles, you can still vaccinate and protect the contacts, but it's actually too late with mumps. Mumps doesn't protect you after exposure, which is interesting. And the other thing about MMR, which is brilliant, is that if you're not sure and you're giving somebody a second or a third or even a 4th dose of MMR and they're already immune, nothing will happen. Their antibodies will kill the vaccine strain of the virus and forget about it. So there is no harm in giving extra doses of MMR if you're not sure, or even MMRV. Sorry? Of mumps?
When the families come in from...
Great. All right, so the question is, if somebody's got mumps and then the family comes in, what is the point of vaccinating them with MMR? Because you're not going to protect them. That's exactly why I'm talking about this now. So you're ahead of me. All right, so why are we getting these outbreaks, first across the top end and then in Indigenous communities, starting in the northwest? Why are the cases mainly in Indigenous people? Is it something about the genetics of being Aboriginal or Torres Strait Islander? Is it perhaps that in days gone by people got invalid doses because we were not looking after the cold chain? Or is it simply that these are poor communities who live in really overcrowded conditions? We didn't really know. And if we're getting mumps now because there's something wrong with the vaccine or there's a strain going around that is resistant to the vaccine, why would it only be happening to Indigenous people? It doesn't make sense, does it? So initially there was a lot of work went into trying to explain what was going on. Why suddenly are people not getting immunity lifelong from mumps vaccine, and why is it happening to Indigenous people more than anyone else? Right. So what was it about? Was it under-immunised cohorts? Maybe their vaccination rates in the past were just not very good. Was it spoiled doses? Was it waning immunity? Maybe they were running out, over time their immunity was dropping off and then they were no longer protected. And why Indigenous? Perhaps it's just the overcrowding. So we didn't really understand what was going on last year or even this year. So if you look at, that's the cases that happened in Doomadgee, and then a few months later happened in Mornington. What's obscured there is that just behind this screen here, at 40 weeks we had some more cases. So why would there be further cases after 40 weeks after we thought that the outbreak had stopped? Well, the answer is that the outbreak didn't stop. This is just notified cases. They got sick of notifying. Yeah, well, what's the point? Go home. There's nothing you can do. There's no treatment. So they stopped testing and they stopped, therefore, giving us notifications. In fact, the outbreak on Palm Island, Yarrabah, Doomadgee, Mornington has gone for closer to 12 months than 3 months. Yeah, so you're still seeing cases out there, I presume.
People are been coming in, but they're saying, oh yeah, I took it ages ago, it's really bad, and it was first.
So they're not even bothering to come to the hospital. Everybody knows it's the mumps. Everyone knows that we can't give them anything to stop it. And so why even bother coming in? Quite correct. So don't be misled by some of these graphs. This is just the data that got into the notification system. And of course it's still happening on Mornington and Palm and other communities. How do you test for mumps? Well, you do a viral throat swab. It's pretty easy. The trouble is that you can miss it if you don't do it soon enough, because you can miss the virus goes away after a week or so, isn't it? The problem with antibody is that a lot of the cases are happening in people who've been previously vaccinated, and they will have IgG, but it doesn't mean that they've now got mumps. So antibody there, too early, too late. Somebody who's got waning immunity, the antibody doesn't help you much. So often it's just a clinical diagnosis, or otherwise you'd have to do 2 blood tests 2 weeks apart to show rising antibody, which is difficult. You had a question?
So, if they have had previous vaccinations, do they then, like varicella, do they then get the vector disease?
All right, the question is, if they get it the second time, if somebody who's vaccinated gets it, is it a milder disease or is it still a severe disease? As we said, the older you are, the more severe it is. What we're seeing now is in these outbreaks, many of the people have been vaccinated and it seems to be milder disease than is in the books from before the vaccine era. So fewer complications, milder disease, which is reassuring. But I'll go on. All right, so I told people in these communities, well, there's no point, stop testing. And I was ticked off by the branch in Brisbane who said, no, all of these cases must be tested and counted in the database. But of course, people aren't even bothering to come into the doctor. So we know that we're only recording a fraction of the mumps cases. Yep. Yeah, so we've been seeing them in 10 to 40-year-olds, right? But of course, classical mumps before the vaccine era was happening in toddlers, the under 5s. Now we're seeing it in even in some young kids who haven't been vaccinated, but in older people, many of whom have been vaccinated. So we issued an alert. We told people that you really, vaccinating the household contacts is like shutting the door after the horse has bolted. It's not going to work. What you actually need to do is vaccinate the rest of the community, a wider circle of contacts, so you can cut out the second or third generation cases, right? So the family of the case have already been exposed and it's probably too late. It's just a sign that you need a higher MMR coverage, even MMR dose 3 in these communities. And so we put out instructions. We want MMR3 in these outbreak communities, not trying to follow household contacts or trying to follow the chain of infection, because you can't. A lot of cases are asymptomatic, a long period between cases, they just appear sporadically in the community. There's no real pattern to it. And the other thing, unfortunately, at the time we were more worried about meningococcal, so we didn't do an active campaign. They were not going out. They were doing it passively for people who'd come in. And so, effectively, we didn't stop it and it just kept going. But we had other priorities at the time. So you can see from this that particularly in the age groups, younger age groups, most of the people getting mumps had been vaccinated once or even twice with MMR. In fact, if you just look at that graph, you would say, oh, bloody hell, it looks like MMR is a risk factor for getting mumps. What's going on here? Why would most of the cases be vaccinated? Can anyone explain that? Well, yes, but why are most of the cases vaccinated?
Is the efficacy of mumps not as good as the others? Or?
When they brought MMR in, it was brilliant against mumps. So why has it changed? All right, let me just explain the graph to begin with. If the underlying population that you're taking the cases from is nearly all vaccinated, then it's not surprising that at least half of those who are getting mumps are also vaccinated. It's just a reflection of the underlying vaccinated population, right? You're still at far higher risk of getting mumps if you're unvaccinated. This is just an artefact from the fact that the underlying population is vaccinated, all right? So it's not a risk factor. Don't go out of here saying that I said that MMR causes mumps or they'll kill me, right? So that's just an artefact of the way that we're doing our research. So check the vaccination status of your Indigenous or, in fact, any client. As we know, the rule hasn't changed. Anyone born after 1965 who you can't lay your hands on records saying that they've had 2 MMR, give them another one, unless it's contraindicated because of immune deficiency or pregnancy. Yep, anybody, anytime, at least 2 doses of MMR. Let's be clear on that. But in these outbreak Indigenous communities, we went further. We said, we want 3 doses. You don't have to go looking for records. You don't have to satisfy yourself. If they have had 2, it doesn't matter. Just if they've had 2 or 1 or none, just give them an MMR. We actually did that in the prison here. You know the prison is more than half Indigenous residents. First dose of mumps, we vaccinated hundreds of prisoners, and not just in that cell block, but around that and around that. And it was only 1 case. I'll tell you what, the blokes, as soon as we told them about orchitis, they were lining up to get them MMR doses. So we used about 1,000 doses with the Prison Health Service and stopped the outbreak. In Cairns, Lotus Glen, they mucked around. They didn't do that. They had dozens of cases. Yeah? So we know that the vaccine works. This is the funny thing. If the vaccine works, why are we getting these outbreaks? Why is the vaccine waning today when it wasn't waning when they invented the vaccine? In those days, they thought it was lifelong. Were they wrong? Well, all right, so far, that's the whole of state data at the top and just the highly affected areas at the bottom. And you can see it's still mainly Indigenous people, although it's spilling over into the rest of the community. We're seeing more mumps. So much so that I would say that you as health workers, if you're exposed to mumps cases and you're not pregnant, have another dose. Right? It won't do you any harm. Because you're at risk because you're seeing all of the cases. Again, statewide, the same thing. A lot of the cases are immunised. This is showing by district or by community that these outbreaks are actually lasting much longer than 3 months, more like 9 to 12 months. Or by HHS, you can see Northwest has gone on for quite a long period, about 10 months. And now it's finally coming to an end in Northwest. It's also happening in other countries. The mumps is out there, mainly, again, poor and Indigenous communities. So it seems that this thing about more opportunities for the virus to spread is important. This is the theory that explains what we're talking about today. In the early days, when people were getting MMR, the vaccine, the natural wild virus was still circulating. Right? If you've been immunised and then you encounter this virus, you're getting something called natural boosting. It means that even without getting sick, you're getting a booster dose against the virus. Right? Now, today, with hardly any mumps circulating, our immunity is not getting natural boosting and it's beginning to wane after 10, 12, 20 years. In the United States, they're saying the average duration they're getting from the mumps component of MMR is probably 27 years, but there are some people with much less. So the reason why mumps vaccine was working beautifully in the past is that wild mumps were still around. We've had many years now without wild mumps, and suddenly we're seeing waning immunity, all right, because of a lack of natural boosting. All right, so that means that it's not just the accumulation of susceptible people that's causing the outbreaks. We're certainly seeing milder cases in the older people because they've got partial immunity, which is reassuring. But what we're predicting is that we're going to have these slow, grumbling outbreaks extending from the Indigenous to the non-Indigenous community that can last months or even years. It might completely go away and then come back in another 10 years or another 20 years. All right, so the theory of natural boosting probably explains some of the patterns that we're seeing with mumps, but also measles and varicella virus. All right, so the concern with varicella, again, is if we eliminate it in the wild, then people are not getting the natural boosting and their immunity might fall off. And perhaps we're going to see more shingles. So there are all these sorts of concerns that we need. But the end result of this is that you will see more mumps. We do want them notified, at least initially, that you're seeing them. Therefore, you should test. People at risk, including health workers, really should think about maybe having a third dose of MMR themselves, because this thing is back. Yeah. There's nothing wrong with the vaccine. The virus hasn't changed at all. It's just about the lack of natural boosting. I hope you understand where I'm coming from with this. All right, so once again, it's all about herd immunity and coverage. Herd immunity depends on how effective the vaccine is, how infectious the thing is, the disease is, and all of the things about recording, timeliness, and catch-up. So thank you. I've got another quick talk from Michelle. My last slide is just to remind you that my colleague Paul Van Binder has got some brilliant videos these days about vaccination issues. He's our Gold Coast physician, and he's really good on media. So look him up on YouTube, and you'll get some